Hey coders, today I want to talk about the 5 most common HCC coding errors that I see every day. And these are the same issues that lead to missed risk scores, failed audits, and compliance problems. Before we get into the errors, let's start with the basics. HCC stands for Hierarchical Condition Category. These are diagnoses used by Medicare Advantage to predict how many healthcare resources a patient is expected to need the following year. In simple terms, Medicare uses HCCs to help budget. Sicker patients are expected to need more care, which results in a higher risk score. But here's the key. Only properly documented diagnoses count. Error number 1, no documentation support. This is one of the most common errors that I see. A long list of diagnoses is not enough to support HCCs. For risk adjustment, the provider must show supporting documentation for a condition. Many organizations use the MEET framework or monitor, evaluate, assess, or address, or treat. While CMS doesn't say the explicit number of elements that are required, there are some auditors that expect that there are at least 2 out of the 4 elements of MEET to support a condition. Another acronym that providers use to help support the conditions documented is DSP. It is Diagnosis, Status, and Plan. For example, hypertension, stable, continue lisinopril, clear, simple, and defendable. Error number 2, not using the most specific or correct combination code. The ICD-10-CM includes combination codes for conditions that are commonly related, such as hypertension and chronic kidney disease, diabetes and chronic kidney disease, or hypertension and heart failure. Per the ICD-10-CM with guidelines, these conditions are assumed to be related unless the provider clearly documents that they are not. When a combination code exists and unspecified codes are used instead, risk is often underreported. Capturing the most specific code matters, not just for accuracy, but for proper risk adjustment. Error number 3, conflicting documentation. Documentation must make sense and be consistent. The most common example I see, because I work in nephrology, is CKD staging. For example, CKD stage 3B/stage 4. This can create a problem. A patient can only have 1 stage of CKD per encounter, and this is what is current on the data service. Patients often fluctuate between CKD stages. However, the provider needs to clearly document which stage applies today. For example, patient fluctuates between CKD stage 3B/stage 4, currently CKD stage 3B based on labs. That clarity is critical. Error number 4, resolve conditions documented as active. This one comes up with cancer a lot. Cancer only risk adjusts when it is active, meaning the patient is currently receiving treatment or has an active disease. If the cancer was surgically removed, treatment is complete, and there's no ongoing therapy, the cancer is considered resolved. In these cases, it should be coded as a history of cancer, not an active malignancy. Active versus history matters, and coding it incorrectly can cause serious audit issues. Error number 5, unconfirmed diagnoses. In the outpatient setting, ICD-10-CM guidelines are very clear. Conditions documented as suspected, likely, possible, or consistent with cannot be coded. For example, the documentation says suspected congestive heart failure. This would not support I-50.9. Until the diagnosis is confirmed, it should not be reported. Report signs and symptoms instead. These are the 5 most common HCC coding errors that I see every single day. Which of these HCC errors do you see the most in your charts? Fixing these issues improves accuracy, reduces audit risk, and ensures appropriate risk capture. Follow for more coding tips, and as always, stay sharp, coders.